At Palmetto Health Richland, we are implementing a Thoracic Enhanced Recovery After Surgery program, or ERAS. The ERAS protocol brings together preoperative, intraoperative, and postoperative interventions with the goal of decreasing patient length of stay, decreasing opioid use, and ultimately reducing costs for both the patients and the hospital. This brief video will provide a concise explanation of ERAS, including an explanation by Dr. PT. Thoracic surgery incisions are considered some of the most painful. Minimizing stress associated with pain and the psychological response of having surgery are goals of ERAS. Non-opioid pain management strategies are initiated in the preoperative phase of ERAS. Patients will take Tylenol, gabapentin, and Celebrex preoperatively. They also will be provided with a comprehensive education program in the clinic prior to surgery. Patients will drink Gatorade the night before and on the way to the hospital. This carbohydrate-rich intake has been shown to decrease insulin resistance and reduce postoperative hyperglycemia.
Today, in an effort to try and communicate more effectively and easily with you guys about something that we're trying to implement for our thoracic patients. As you guys have probably already seen, we're doing some different things for pain control than we had done in the past. Namely, we're doing something called a paravertebral block most of the time, and sometimes we've done a cryo ablation of the intercostal nerves. These will replace the epidural catheter as post-op pain management. The paravertebral block is a block using a long-acting Marcaine that we put in similar to a rib block that lasts 36 to 48 hours when they work, much like an epidural. When they work very well, and they give us about a 36 to 48 hour window of pretty good pain control to the chest wall. This will be the most common thing you see. Occasionally, instead of that, or in addition to that, we use cryoablation, where we use a probe that uses liquid nitrogen to essentially freeze the intercostal nerve at multiple levels and block pain to the chest wall for from 30 to 90 days. We'll use this more likely if we have to do a thoracotomy to try and give them long-term control, and we'll do that probably in conjunction with an epidural, hoping that the cryo will last once the epidural's out to give them continued pain control and comfort. We're doing all this now as part of what's called an ERAS, or Enhanced Recovery After Surgery program. That's an acronym which I know you guys are very fond of. So the ERAS program is a combination of multiple non-narcotic meds, pre-op education, intra-op changes in the anesthetic management, the use of adjuncts like paravertebral block and cryo, and then post-op non-narcotic pain management adjuncts to try and increase patient satisfaction, decrease length of stay, decrease opioid use, and increase mobility and pulmonary function. So this program we know works. We've already implemented a number of components. The current efforts are going to be aimed at standardizing what we're doing, getting new order sets that are much more clear and defined so that we can manage these patients in an easier fashion that hopefully will make more sense to you guys and be more standardized across our patient population. So to review the anatomy of the area we're talking about, this is a cross-section of the patient. Here's the vertebral body, the body itself, and then the posterior process here, and transverse processes here. These are the paraspinal muscles, the spinal cord's here, lung on either side, and the pleura here. This is the actual pleural space right there, the parietal pleura and the visceral pleura. And the space that we're aiming to hit is this triangle here. This space communicates up and down the spinal column. So if we inject here into this space, we get spread in both the caudad and craniad directions to hit more than one nerve root. And you can see this is where the nerve roots come out. and so we'll get a good anesthesia to this nerve root and numb this entire section of body wall. And that's kind of the concept. And as I said, the anesthetic we're using is a combination of regular Marcaine, which, as you guys know, has, I think, a 6 or 8 hour window, I believe, of efficacy, and then a Marcaine that's actually packaged in little fat globules or liposomes. This is called Exparel, E-X-P-A-R-E-L, and the Exparel is a slow release over 36 to 48 hours. So that's sort of the anatomy. The technique uses the patient. Now this patient is actually sitting upright, so this is pre-op. Our patients we do once they're asleep and laying on their side and prepped and draped for the thoracic portion of the procedure. But we use an ultrasound probe, and this is where the spine is posteriorly. So we're off to the side that we're going to operate on. The probe is oriented like so. We start scanning out here on the rib and then move the probe medially until we find the transverse process here. And the look changes. This is the rib. It's a little flatter from this direction, so it's wider this way and more narrow this way. And as we move medially, the transverse processes are more blocky. They're more square-shaped in cross-section. And once we find that transverse process, we place the needle in and put the needle into this space right here. And we put the needle in, hit the transverse process, and then step off and down into the space that we want to be in. And then we inject. And this is it using the ultrasound video, or the ultrasound image rather. This is the transverse process. The pleural line is right here. We want to get below the muscle, just above the pleural line. And as we inject, we can actually see this pleural line push down as this space fills. And that's how we know we're getting into a good space. And this is where we're going to be. And there's just some more pictures, but that's the space that we want to be in. And this is where we inject. And we just inject that combination of drugs into that space, and then it will spread up and down. And here's a good image of the pleura and the anesthetic actually in the space filling it. And what we'll do is just move along the body wall, and we'll inject. I generally won't inject in every space, but I'll try to hit 5 or 6 spaces as high as I can go and as low as I can go. We usually get about 50 cc's of the combination drug, and we'll inject about 10 in 5 different spaces to completely use all the drug. And we get a nice spread in this little space here, and good anesthetic. The cryoablation probe is very similar to this one here, and this exposed piece here is metal, and it's really a simple thing. It has circulating liquid nitrogen that runs through here, and you lay this probe against the tissue. We do this from inside the chest, and let's see, actually, just to give you a little bit of an idea, we lay the probe in this general area here in each intercostal space, and we hit the intercostal nerve with a freeze. It takes about 2 minutes per intercostal space, and we try to do 5 or 6 intercostal spaces, and that ablates the sensory portion of the nerve. That's the most sensitive portion to the freeze, and we just hit a bunch of spaces from the inside and ablate the nerve, and that takes about 30 to 90 days to recover depending on the patient. And as I said, these would more than likely be cases where we do a thoracotomy and use the cryoablation. It really is mainly a cost issue. The probes cost about $2,500. The Exparel dosing cost about $2,500. So they're about equal in cost, and we really don't want to use both of them because we don't think that's going to be particularly cost efficient. So we'll tend to choose between the two, but we won't be doing this very often with the cryoablation. We'll be doing more of the Exparel. Once we get this order set built, they'll come out with a post-op thoracotomy enhanced recovery order set, or ERAS order set, that will include all the information that you need to take care of these patients. Hopefully they'll move along a little faster. They either won't have Foleys or will get them out very quickly. We'll try to manage them with an entirely non-narcotic strategy if we can, but of course the goal will be to keep the patients comfortable. So we have different adjuncts that are narcotic that will be built into the program. So that's what you'll be seeing. Thanks.
Post-operative thoracotomy patients will receive IV fluids at 75 milliliters an hour for 1 liter. Scheduled Tylenol, gabapentin, and Celebrex will be ordered, and patients may have PRN Ativan for anxiety related to pain. Celebrex will not be given to patients having a pleurodesis related to increased risk of bleeding. It is also not to be given to patients diagnosed with CAD or kidney disease. These patients may eat and drink immediately after surgery and need to be up and moving as they are stable and able. It is not a mistake that IV narcotics are not ordered. We are tracking these patients' recovery after surgery and hoping to minimize narcotics usage. According to evidence-based practice, achievement of homeostasis and pain reduction after operation while reducing opioid exposure has been shown to lead to improved outcomes in surgical patients. Implementation of the ERAS program aids in the commitment that Palmetto Health makes daily to our patients. We strive to provide care with excellence and compassion.